ask that we're going to just hold all questions to the end after all three have presented. So feel free to type anything in the chat or in QA, and Carly will hang on to those and the gals will answer them at the end. So, all right, so let's start with Heidi.
Okay. All right, I'm just going to get everything up and running here. Thinking. All right, so here we go. So some objectives that the team of us here are hoping to cover when we present today is just our roles as speech language pathologists, occupational therapists, and physical therapy in regards to quality stroke eval, interventions, and just the strategies and techniques that we can provide to continue to support that ongoing neurological healing in relation to all of our areas of specialty. So let's start with the speech side of things. So as speech pathologists, we really work to assess and diagnose and just treat speech, language, voice, social communication, cognitive communication, which we're kind of referring to as the thinking and memory or those higher level cognitive skills, and swallowing disorders. In regards to our patients who've had strokes, we will work across the continuum. We start out with that acute care hospital, inpatient rehab, home health, outpatient, or the community levels, just to really help patients with their ongoing healing after a stroke. When we get a new patient, we're going to review that neuroimaging with all that wonderful information that Marie shared, kind of look at where the damage was done in the brain and read through the medical charts of all of those other medical history issues that might be playing a factor in their patient's recovery process. We will interview our patient and their family members. We really want to get their input on what was a pre-morbid skill, what were the patients doing before, kind of figuring out strengths and weaknesses, and what are their goals? What do they hope to achieve and accomplish through the interventions and support we can provide? We will provide patients with formal assessments and those ongoing informal assessments. I think that it's been touched on a little bit here today, that, you know, patients might look great on a formal evaluation, especially if they have had all these wonderful medical interventions we've been able to provide on the neuro level. But then when you talk to them and delve into some of those more just functional things that assessments don't pick up on, patients do still have issues. So there's a lot of support and strategies that we can provide as professionals. We will continue to assist them with that return to household demands, driving, work, school, and just that overall independent living. So I just want to touch on that stroke is an acquired brain injury, and as such, we see multiple changes in our patient's individual level of functioning. So I'm going to try to touch on the specific areas as quickly and accurately as I can in the time span I have, but this is by no means comprehensive in regards to what a speech language pathologist can provide. So first, language. Aphasia would be the medical term that refers to difficulty with language. There are a few types of aphasia. We could see a receptive or a Wernicke's or fluent aphasia. This would mean impaired comprehension of language. This might present with our patients having difficulty understanding yes, no, or simple open-ended questions. What do you want for supper? Or how was your day? They can't understand what you're actually asking to be able to formulate a response. Individuals might have difficulties following commands or directions. Difficulties with reading at a variety of levels. Oftentimes, a receptive aphasia patient will have fluent verbal expression, meaning that it's accurate words, but it just doesn't make any sense. So they might, well, here, I'm going to play an example, and this will hopefully make a little bit of sense here. Okay.
Hi, Byron. How are you?
I'm happy. Are you pretty? You look good.
What are you doing today?
We stayed with the water over here at the moment and talked with the people for them over there. They're diving for them at the moment. They'll save in the moment. He'll have water very soon for him. With luck for him or for them.
So you can kind of see that that little Myron there is giving a lot of information or answering with words, but it doesn't make any sense. So back to, so that receptive aphasia, some things we might like look at is as a caregiver or provider, you have to break stuff down into shorter segments or simpler tasks just to help really support the communication abilities of our patient at that level. The next one would be expressive aphasia, or Broca's, or non-fluent aphasia. And this is more impaired verbal or written language. Our patients might have difficulty saying their basic words, or they may omit words when they're talking. Individuals might speak in very short sentences. We might clinically see that they have trouble naming places or objects, that word finding. They just can't connect the dots and come up with the word they need. They can have difficulties listing or generating their own thoughts and comments, and then problems with that written language as well. So here's another kind of example.
Can you tell us your name?
Mike Caputo.
And Mike, when was your stroke?
I was 7 years ago,
Okay.
and
And what did you used to do?
worked Autodesk, seven sales, and world.
Over there,
Okay,
when you turn your
That's
head.
my
so with Mike there in his example, you can see he's got some details and some information that there's obvious gaps in the word finding. A lot of individuals with that expressive aphasia, like it said, their intelligence is intact. They know they're having difficulty, but they just still can't connect it. So it's very frustrating. And then another level of language that we might see is a global aphasia, where individuals have difficulty with both the expression and comprehension. What we'll do in therapy and evaluation is trying to find some modality, some method of being able to communicate with those individuals, and also have them be able to communicate what they need or what they want. We might use some picture boards or sort of another form of augmentative or alternative communication, and then build from there. But there's lots of options and lots of wonderful therapy techniques that are helping our individuals who experience any level of aphasia. Some basic tips or strategies to help with language is just breaking information down into smaller, simpler steps. Giving choices, like, do you want a cheeseburger or do you want pizza? You know, breaking it down into a few things, or even showing the visuals of those choices at times too. Supporting language with gestures or written language, or like I said, pictures. Across all of my types of issues that speech pathology works with, a big strategy is decreasing distractions. I know for myself, even when I perceive myself as functioning fairly well from a neurological standpoint, but if I'm distracted, sometimes even my best days are not very good. So distractions and getting rid of them as much as we can will help any patient across any area of difficulty. With language, you can help them talk around the word, help them try to find the word a little bit on their own by giving some of those cues. And then when they get it, reiterating that word so that they can really kind of connect it and find it a little bit better the next time. Support their language, support that neurological healing and ongoing growth of their word finding abilities. Sometimes you can label items, you know, putting the name on it so they see it, they hear it, they visualize the written word too. It can help connect the dots a little more. And always remember just to talk to the person in an age appropriate manner. Just because they might have a language issue doesn't mean you should treat them younger than what they are by any means. Another area that we will work with in speech is different speech production and voice changes that patients might experience after a stroke or any other type of an acquired brain injury. So dysarthria, and that is the medical term that refers to unclear speech productions. Patients' speech might be slurred or mumbled. It might be hard to understand because they're just not precise with their consonant or vowels. They can have facial weakness, you know, with that one side of the facial muscles, you've got your lips, your cheeks, all of those muscles, they can be gone. We use all of those muscles so intricately to produce our speech and to be clear. And if half of them's not moving, it really distorts what we're able to say. Patients' rate can be changed. It can be really slow and laborious to try to get words out, so it's hard to coordinate their breathing then with that. So just overall control of that system, respiratory and articulation. And then we can also see voice changes. They can get really spastic or strained and strangled with their voice or their speech because their anatomy and their muscles is not coordinated or working together because of neurological changes. Another area that we can see after neurological changes is apraxia. So apraxia directly refers to deficits with the motor programming. So a patient might know what they want to say, and they might actually be accurate with that information on one instance, but the next time they try to say it, it's going to come out a different word entirely at no fault of their own, but there's just a mishap in the connection of what I want to say and then the motoric completion or follow through of the ability to say that word. So if I might want to say, hey, go get that bottle from the kitchen, it might be get that bottle from the chicken or the mitchen, or just filling in different speech sounds for that word and not accurately able to say it. So here's a little bit of an example of a patient with apraxia. Just pay attention to the effort it seems to take for her to formulate some of her words and thoughts here.
Today is my birthday. This last year suck.
So in therapy, with speech production issues, we're going to do a lot of drill work, a lot of repetition, working on speech strategies that work really well for our patients that we've kind of honed out just to make their speech as clear and accurate as possible. And then training to carry over those strategies in their functional communication outside of the therapy office as well. So some strategies and tips are just, again, limit those distractions. If we're in an environment where we're paying one-on-one attention to what people are saying, it's going to increase our intelligibility or the accuracy with understanding what our communication partners are saying and doing. Pay attention. Restating what you think you heard, like, okay, I'm hearing you say this word, is that accurate? So that you're not having those gaps or mishaps in that communication. Sometimes using smaller, shorter words or talking in shorter sentences can be really helpful. Encourage good breath support on your own too. As a communication partner, if you pause more and naturally use a slower rate, it can support that from the other individual you're talking to as well. So kind of being a good model as well as the support. Talking loud and going slow, those are both going to really help with that over enunciation and clarity. So swallowing. I just wanted to touch on a little bit. It's not written in the slides here, but as a stroke center here at Sanford, and like when I work acute care on the weekends, that's what we see patients for. There's a patient called in with a stroke code and speech is consulted right away for dysphagia. So that's the primary thing that the patient's plan of care will start with. We're going to rule out and make sure that they are safe to eat and drink orally so we can avoid any aspiration pneumonias, because we know aspiration is going to be so debilitating in terms of that patient's recovery. Hold on, I'm sorry. You guys can probably see that message. My computer thinks it needs to restart it a little bit. We're just going to snooze that. I don't know. I'm sorry for that interruption. But anyway, in regards to dysphagia, like I said, we're consulted right away on that. We'll do a swallow study and check out what's going on with that patient. The reason swallowing is so important is because we want to avoid aspiration. With the stroke and that neurological change, patients, their muscles can lose that strength or coordination. And then we might see that they're pocketing their food, it's sitting in their cheek. So then when they're done eating and they go to talk or something, they're at a high choking risk or having issues with clearing that food out safely. Their swallow timing can get delayed. So then we might have to thicken liquids or change the consistency or textures just to really support that they're eating and drinking safely still. And then I did include, I won't go over those, but some of the concerns that aspiration can present. And that is a conversation that we have with patients and their family members a lot, just to help with that decision process and to really promote as much of a safe, but also the least restrictive diet as possible to really look at quality of life throughout that healing process too. In therapy with swallowing, we're going to typically do swallowing exercises. We want to try and impair the strength of those muscles, and also coordination exercises, timing and control, just to kind of get everything clicking the way it's supposed to again. We'll teach swallow strategies. I do a lot of outpatient x-rays of individual swallows, and it's always, what strategy can I make the patient? Can they do a head turn? Can they do a chin tuck? Can they do a bolus hold where they hold it in their mouth, get ready to swallow and swallow? Whatever is going to work to keep them on that, we call it the least restrictive diet, but it's basically the diet where we have the least amount of changes and thereby the best quality of life. Many people don't enjoy thick and liquids, so if I can do something to keep them on those thin liquids where it's safe, I'm going to try that technique as much as possible. But we really help a lot with that swallowing throughout the process. Okay. There it goes. All right, so some tips for swallowing. And again, follow the recommendations of the therapist who assessed the patient. These are just some kind of generic ones. Using a slow rate, focus on the eating. I think I talked later, don't talk with food in your mouth. If we can focus on the task that we're doing, then we're going to set ourselves up for more success. Again, limiting the distractions, small sips, single bites. Sometimes a dry swallow is helpful if we're not clearing everything out. Just swallowing again can kind of help clear it, so if we don't have that extra food and stuff left over as we're adding more to our mouth. And kind of one of the last areas I'm going to touch on in terms of what we do as speech pathologists, and this is a huge area to try hone in on, so I guarantee I've missed some elements, but cognitive linguistic deficits, so those cognitive skills. What we might see is that patients can present with impaired attention. They can't focus on the task. They're easily distracted, or their attention is pulled by internal thoughts or something they see visually or something they hear. So working on that. Individuals might experience difficulty with problem solving or reasoning, kind of thinking through the steps or activities to complete a normal task. It's just not all clicking anymore. Memory recall, slower processing rate. Sometimes they'll see that patients, they can complete the task, but they can't complete it at a pace that would be safe enough for good decision making in the moment. So working on that processing and trying to increase that rate where they're still accurate and safe. Individuals can experience trouble with organization or just the categorization of their thoughts or their demands throughout the day. I think of my office. I try to keep my office as organized as possible, because if I have piles of stuff or things all over, it's distracting to me. And then it's like, where do I start? How do I break it down? But if you're organized, you can be more successful, it seems, and complete things in a more timely, more diligent, more efficient and accurate manner. Impaired executive function skills. So some types of executive functions would be that initiation or starting a task, knowing, okay, yep, my alarm went up and I got up. But now what do I do? Oh yeah, I should get dressed. I need to go get my clothes out of the closet, pick out an outfit and get ready for the day. Knowing to start those tasks in the moment. And then also on the other side, inhibition, knowing when to stop the task. Sometimes we might see where patients are verbose and they just keep talking, even though it's maybe not the most appropriate topic or appropriate statements for things too. Judgment concerns and issues, planning, both the development and the execution of a plan. And then we talk about working memory, which is, knowing information that we hold in our memory, but then being able to kind of manipulate and apply it with the purpose of carrying through a task and being successful with the task itself. And mentally shifting, that transition between activities and between tasks, while still being accurate in the moment, and being able to pick up where we left off and move on with our responsibilities and demands throughout the day. Another big area that we might see in regards to cognitive linguistic is just a decreased awareness. Anybody, if we're not aware we're having an issue or a problem, or we don't call attention to it, we can't fix it, and we don't improve on our skills or abilities in that respect. So that can be an issue. But with the cognitive linguistic deficits, some functional examples you might see are individuals forgetting appointments or starting a task, but then never carrying it through. I've got like 15 projects going, but none of them are done. Missing steps to the tasks they're doing, or just not knowing how to manage their finances. So in therapy, we work on a lot of functional hands-on reasoning and problem-solving tasks to help build those skills and then help them actually apply them to their daily demands or vocational, their work demands. And we'll also do higher level cognitive demands. So something to keep in mind is that, that stroke recovery, it doesn't take that 2 hours a day, 3 days a week that we might see the patients if they're coming for a few therapy sessions. But it's an all day, everyday process. Each task we work on and complete every day in our daily functioning is working towards improving our performance and healing from a neurological standpoint. So I think being a support system and always encouraging that practice is really important to just further that neurological healing. So some tips and strategies. It's helpful to keep a daily routine or schedule of events. If your brain kind of knows what's coming next and stuff, it gets into that nice cycle and can prepare and be more successful and more efficient. Planners, calendars, to-do lists, write things down. That's a huge support for any memory, organization, and just even completion of tasks. If I know what I need to do in my steps, I can check it off as I go and cross it off as we work through it. Limiting the distractions, again, just anything we can do to support that attention. If you're not paying attention to something, it's really hard to be accurate and successful on it. Avoiding multitasking. One task at a time really does support improved success. There are obviously times in our life when we have to multitask, or many of us multitask all the time. Some of you are maybe multitasking now. But if we're really on a task that's really important, focus on it and try to cut out some of that multitasking to improve your success. More challenging tasks early in the day when your brain is fresh is really helpful. Kind of structure that day. That can go with that routine that the therapist might help the patient work through. I'm going to balance my checkbook and go through my finances after breakfast instead of after I've done all of my therapies and my homework later on in the day. And the good quality rest, the brain breaks, as Sandy brought up, super important. And exercise, as Marie said, that neurogenesis, like they're finding so much more research and studies on that aerobic exercise and how it's going to support that neurological healing. So that's really important. And then asking for help and just ensuring that clear communication. So from a speech pathology standpoint, our goal is always just to, optimize what our patients and their caregivers need for support to improve their overall skills that we address and work with. So, and just support that good quality of life and return to their functions and their goals, what they have set for themselves. So I'm going to step aside and let Teresa kick in.
Right, again, I'm Teresa from Occupational Therapy, and we are going to now just talk about OT's role in stroke recovery. So firstly, I want to talk about what is occupational therapy. I think of all the three disciplines, it is the most least understood. So we have a little humor that we have posted in our OT department. It's a little clip or a meme from Orange is the New Black. It says, when the stranger I'm talking to knows what occupational therapy is. Hallelujah. All right, so occupational therapy, OTs, work to help people across the lifespan to do the things they want and need to do through the therapeutic use of daily activities. Occupational therapy practitioners enable people of all ages to live life to its fullest by helping them promote health and prevent or live life better despite injury, illness, or disability. But why is it called occupational therapy? So in a nutshell, occupational means the things that occupy your day, the daily tasks that we do each and every day. And our role is to help people get back to doing those things. So there's really two categories of occupations in the OT world. We consider activities of daily living, or ADLs. So those might be feeding, eating, getting dressed, going to the bathroom, taking a shower, sexuality, sleep and rest. And then instrumental or higher level activities of daily living, IADLs. So things like home management of cooking, cleaning, laundry, grocery shopping, managing medications, school, work, you name it, caregiver training, community mobility and transportation. So occupational therapy's role in stroke recovery. Following a stroke, individuals are faced with multiple challenges, and our OTs address these challenges at all stages. So we're looking at acute hospital settings, acute short-term, long-term rehabilitation settings, home health care, outpatient care, and community-based services. Our job is to help facilitate recovery in clients, and this involves a significant amount of collaboration with not only the clients, but their families and caregivers. I feel that we haven't really done our job if we haven't done some pretty extensive teaching with the caregivers and the families as well. So just to touch on why it's so important to have OT involved in stroke recovery. Research shows that clients who receive OT intervention are significantly less likely to become debilitated and more likely to be independent in their ability to perform activities of daily living at the end of treatment. The deficit, we're going to do a quick discussion now on the deficit areas that OT addresses. I'm not going to go into detail with these because we just don't have time today. But the deficit areas that we evaluate and treat would be motor impairments, sensory impairments, functional cognitive impairments, and functional visual impairments. And we're going to just touch base on two areas, the functional cognitive impairments and the functional visual impairments. I'm going to just touch very briefly on functional cognition because Heidi's already done a wonderful job of that. But with OT, our role is to work on functional cognition during those daily tasks. You cannot possibly perform daily tasks, and especially the higher level tasks, without having your functional cognition skills in place. And I think when you put motor on top of cognition issues, a lot of times one is going to take over. That ability to even just move through space while managing your cognition is very difficult. So OTs really need to play an important role in that. And then next I'd like to focus on today is the vision deficits and the fact that this is a big area of OT's role, and it's not addressed as much by speech and physical therapy as it is occupational therapy. I think that vision is often a very overlooked area in occupational therapy as well as other disciplines. If you think about vision and your functional vision, it impacts everything we do and how we move through our world. There are both restorative and adaptive visual strategies that can be instrumental in stroke recovery, but also hold up stroke recovery if they are not addressed. Occupational therapists often work closely with neuro-optometrists to address and assist with best outcomes following stroke. Some of the things that I think are the most challenging, though, are that rural areas often do not have neuro-optometrists, and they often don't have occupational therapists who have been specifically trained in this. It's not an area that we go into great detail in when we first come out as therapists, and some of that is learned more on the job. And so it's really important that we have both involved. If you are in a rural area, for neuro-optometrists, Fargo, Grand Forks, Bismarck are some of the bigger cities will have neuro-optometrists. But if you go on to the North Dakota Brain Injury Network and look up neuro-optometrists, it will pull up a list of names and people that may be able to provide some service. Unfortunately, occupational therapy is a little more complicated in finding people, but I would just encourage you to reach out to some of the bigger hospitals if you are a therapist who wants to address these issues and need some guidance. There's also teletherapy, it might be an option, or to set them up with an OT that can maybe do some home programming for you. So next I want to just talk a little bit about some of the general functional vision deficits that we see. It's not limited to this, but I just hit the high points today. We're not talking acuity, that's your optometrist. And the general optometrist is going to deal more with that and diseases of the eyes, where the neuro-optometrist is going to look more at those functional visual deficits that have been impacted by an injury to the brain. So visual field deficits, just in general, meaning that they have a loss of vision in a certain visual field area. When we look at ocular motility deficits, we're talking about the muscles of the eyes. When you think about a stroke in an arm or a leg, the muscles of those arms or the arm or leg can be affected. You can see that as well with the eyes. And then visual perceptual deficits are really how the brain perceives the visual information going in and out. and that can be a significant impact. And then midline shift syndrome. This is a perception of where you are in space is impacted, and it often results in a shift away from the involved side, which significantly can impact balance, mobility, ADLs, ADL transfers. And then there's neglect and inattention. And if you think about that area of not really knowing where your arm or leg is in space, or even anything on that side of the world, it really can impact what you can do in your day and how that plays out with your ADLs. We're usually often seeing a combination of these visual deficits. It's not one or the other, but a multitude of these issues. And often the stroke survivor is not aware of their visual deficits, but it can be greatly impacting their function despite that. Next, we're going to talk about just general treatment approaches in stroke recovery that OT provides. We really take two approaches in a nutshell. Restorative approach, where we're focusing on restoring lost function to achieve maximum level of independence. And then we look at adaptive approaches, where we focus more on modifying the environment to achieve maximum independence. With this restorative approach, we can do task-specific training, motor sensory retraining, and I've listed those, but I'm not going to go through reading all of those, cognitive retraining, and functional visual retraining. Here's some examples of task-specific training where we might do some sequencing of skills, chaining, backward chaining, different things that we might work on to help with task recovery. These are some strategies we use for motor recovery. There's dynamic splinting, functional electrical stimulation, some strength training, some ways to support the arm and help with improved function. And here are just some examples of some sensory stimulation, cognitive and visual perceptual restoration things we use, some gaming systems where we're working on fine coordination as well. Certainly not limited to those things. Those are just a few examples of things that we provide. And then the adaptive approaches, which I think are sometimes more well known in the occupational therapy world by others. So using adaptive and equipment and assistive technology for ADL modifications, home modifications, work and leisure. But we also do a lot of visual modifications and cognitive modifications, as well as driving modifications to help people become more independent following the stroke. Here's some pictures of just some basic adaptive equipment, some real general things that are out on the market. And then there's a few things down below the bowl and the shelf liner that are just things you can find in your day-to-day environment. These are things that are probably well known to most people that are involved in stroke recovery. The center one is driving adaptations with hand controls. The multitude of items for adaptive equipment and assistive technology is just absolutely huge and almost impossible to keep up with, especially assistive technology. A lot of times you need to find a specialist in that as well. All right, we're going to do a really quick little interactive experience. Not quite sure how this is going to go doing it online, but we'll give it a shot. So everybody, I want you, if you're wearing, we're going to put you all in a stroke survivor's shoes for just a few minutes, and then I'm going to explain a little bit more about what OT's role would be with that. So I want you to imagine you've had a stroke. I want you to take, if you have a jacket, a shirt, a sweatshirt available to you, use that, take it off. If you do not have that, maybe you take off a sock and shoe and we give that a try. But I want you to imagine you had a stroke on your dominant side. You have weakness, pain, and some tone or tightness in the muscles of that arm, so you're not able to move it much at all. Imagine you have decreased balance and tip to the side easily. In addition, I want you to close an eye. I know that that's not the same as any visual deficit you would probably experience from a stroke, but it's the best way I can help you imagine it today. You also have neglect or inattention to that side of the body, with some trouble knowing your position in space, and you're having difficulty with new learning. My instructions are to take the shirt or jacket and place it over the affected arm. You will always start with the affected side first. Then you're going to push it up over the arm and up over the elbow as far as you possibly can go. Now don't move your arm. Okay. Then up under the armpit and then over the head and around the back. Now you might have trouble staying upright. Okay. If you have a pullover shirt, then you got to pull it over your head and you can only pull it around with one hand. Okay. If you have a zip up jacket, then try to zip it up. Pretty darn hard, isn't it? Okay. So what our role might be is to teach strategies on how to become more independent with that task. We would do high repetition of that learning over and over again to learn that process. We might do some electrical stimulation to facilitate movement on that side of the body, do some stretching, think about adapting the environment so if their balance isn't good. Initially, when they're going to learn that task, we're going to put them in a chair where their feet are touching the floor and they have that extra support. We decrease distractions and then we gradually challenge them more. So just a tiny little example of things that we might do with someone. All right, next we're going to just talk about staying active after a stroke and community resources. So the joy of exercise. First off, I just want to remind us all of how difficult it is to be accountable for, at least I can say this, my exercise program, how sometimes I don't feel like I want to do it, and how hard it is during the winter months in North Dakota and Minnesota area. And then think about how frustrated we get sometimes with the fact that our patients don't follow our home programs. I'm not going to go through my simple tips right now to stay active, but I am going to hit a few high points. Home programs, keep them simple and realistic. In addition, they need to be motivating. A lot of my patients are not very motivated by exercise. So we got to think outside the box. And so some of my role there is maybe I look at what excites them. You know, I have one guy right now who loves to cook. And I could not get him to exercise for the life of me, but I've got him cooking 3 times a week and doing a lot of cognitive and hand strengthening and things. And then I've been able to gradually, with some planning, add in some exercise. But we've had to do a lot of repetition and a lot of pre-planning to help that happen. And then just to talk about community resources, I listed a few. This is obviously the tip of the iceberg. I just hit up a few high points. They're just support, education, and ways to stay active are these resources. I would recommend considering an assessment by OT, PT, or speech therapy, maybe 6 months to a year post stroke. I don't think we've done that as much in the past as I'm trying to do now. I started it a lot with my Parkinson's patients, and so I've been thinking a lot more about how a lot of these people, they either, you know, we can expect with an injury to the brain, they could decline or they might even get better. So we may be able to offer them some services and at least some ways to monitor how they're really managing post that acute therapy time. I think teletherapy with COVID-19, there's some hope for that to maybe expand and help people, especially in rural areas. And then with COVID-19, I've seen a lot more Zoom, YouTube, online ideas for exercises. I would just encourage people to be consulting with their physicians or their therapists for guidelines on what are the best choices there. And then there's some other lists of resources. The other couple things I wanted to touch on were that I think are easily missed in an area in outpatient therapy. I've really been trying to hit up more is vocational rehab and utilizing them to help get people back to either school or work or some kind of a job process. And then looking more into recreational leisure. I think this gets missed a lot. And with younger strokes like Marie talked about, I think we have to work harder at that. So I listed some things in the FM area and a few things in like Bismarck, Bottineau area. But a couple I would touch on would be like Hope Incorporated. It's definitely more of a sports for disabilities. But it's not just limited to that. They do some other things outside of that, like they have trivia night online. They do some play, they do a fashion show, they do a variety of things, and it's a great social network for people. And they also have a loan closet, so they have like exercise bikes with where they can bike with their arms, but they have like beach chairs to get people down to the beach in the water, because sometimes in a wheelchair or with walking that can be very difficult. Also, Twist of Fate is here in Enderlin, North Dakota, and it's a deer hunting program for people with disabilities that they offer with crossbows, and it's really cool. So look some of those up, just Google them and look them up. The other thing is there are driving specialists in the OT world that help people get back to driving or help assess their safety. If you want to find out if there's a driving specialist, if you just Google driving specialist in North Dakota, pops up on the AOTA, which is the Occupational Therapy Association. You can type in a zip code and it'll pull up a list of providers. So that's all I have time for today. I'd like to end on kind of a positive note with a famous quote by Carl Jung that encompasses our OT mission. I am not what happened to me. I am what I choose to become. Thank you. Now I'm going to turn it over to Lisa from Physical Therapy.
Hi there, I'm Lisa. I'm a physical therapist, and I'll be touching on the physical therapy portion of rehabbing after a stroke. So first, what is a physical therapist and what do we do? Physical therapists are movement experts who improve quality of life through prescribed exercise, hands-on care, and patient education. There's lots of different types of physical therapy out there. The ones that work with people after they've had a stroke is a neurologic physical therapist. And we specialize in the evaluation and treatment of individuals with movement problems due to disease or injury of the nervous system. Physical therapists can help improve or restore the mobility you need to move forward with your life. So that first evaluation day, when we see a patient after they've had a stroke, there's a number of things that we look at. Strength is a big component of that. And we will look specifically at leg strength and also some upper body strength as well, to determine where a patient's at. We'll also look at coordination, balance. And that's especially particular to those cerebellar strokes that have trouble balancing and coordinating their movements. We'll also look at their range of motion, specifically, any tightness or flexibility issues that someone may have after a stroke. We'll look at sensation, if they have trouble knowing where their body is when they're trying to be mobile, as well as reflexes and tone, or how spastic someone may be after a stroke. As you can tell with all those things, if you do have deficits, you're probably going to have issues with transfers, balance, and walking. And so we really want to get a baseline on that evaluation day of how well that patient is doing in their daily life with their transfers, mobility, and walking. And specifically what type of equipment they're having to use, or what type of equipment we might recommend. We'll also address their home situation if they are at home at that time. And to do that, we might, have them describe what type of living situation they're wanting to get back to, or more specifically, where they're at now, whether that's, home stairs, or if even if their environment's a little more crowded, we need to discuss decluttering it or removing rugs and that sort of thing. And a big portion of physical therapy, especially on that evaluation day, is going over an exercise program that is specific to each patient. Because we know, patients that come in a couple times a week for physical therapy, we will show improvement, but being able to maintain that improvement on their own is especially important. All right, so the physical presentation of a stroke that we tend to see that first evaluation day, hemiplegia and hemiparesis are huge components of affecting their physical ability after a stroke. That hemiplegia is the complete paralysis of one side of the body, where with the hemiparesis, we see more so just the weakness. And there can be such a large scale from one person to the next, where maybe they don't have any weakness, or maybe it's just a little bit of weakness on one side of the body, to completely flaccid, where they're unable to move one side of the body. Next, depending on where the stroke's at, we might also see some neglect. or a lack of awareness on one side of the body. And you can see how that'll be dangerous for someone's mobility, because if they're unable to see one side of their body or pay attention to that side, even from like a visual neglect standpoint, it's going to be easy to trip over something on the ground or bump into something. I've even had patients on their way into therapy that'll bump into a doorway and will come in with one arm kind of cut up and bloody on a side. And that's one thing that we try to teach strategies to overcome that. Also with a stroke, we tend to see spasticity, where you've got that prolonged muscle tightness afterwards. And that can really affect walking patterns, ability to transfer. And we'll discuss later strategies that we use to try to overcome that spasticity. We'll also see people with ataxia, which is difficulty controlling movements due to poor sensation and proprioception. And this really affects your mobility and your balance because you have trouble controlling your movements. All of this can lead to poor balance and falls, and preventing falls is kind of one of the main components of PT that we do for any of our patients, but especially those after they've had a stroke. Ultimately, our goals for PT are to improve your quality of life, make you as independent as possible. We want you to be safe when you're on your own, and we want you to be able to cue yourself to be safe as well. Ideally, we're going to work our best to help you return home, return to work, or return to recreational or social activities in any capacity that means, whether that's the way that you did them prior to the stroke, or adapting or compensating in certain ways to make you successful after the stroke. Physical therapy starts right away once a patient is medically stable after a stroke in the hospital. A lot of research points to the fact that early mobilization in the hospital is key to having the best outcomes for a patient's mobility after a stroke. And then, as the other therapist and Marie touched on, there's also, if a patient's not ready to return home after a stroke, there's high intensity and nursing facilities that would be options for somebody to rehab for a period of time before hopefully returning home. If a patient's not ready to go home right away after a stroke, home health always is an option where the physical therapist can come to the patient. But ideally, the goal after a stroke is eventually to get to outpatient therapy for continued recovery, so that we can challenge a patient in a more dynamic environment and help them return to all previous activities in some sort of capacity. As I touched on briefly earlier, there are, ideally, we want everyone to recover to the best of their potential after a stroke to regain that normal strength and gait pattern. Not everybody has complete recovery after a stroke, and that's where that compensation comes into, where we use various bracing or assisted devices to help walk, or wheelchairs so that somebody's able to participate in their daily activities and leisure activities or return to work in some capacity by compensating. This next slide is just some examples of different equipment that we may use for assistive devices for a patient, whether that's canes or walkers to help somebody walk in a safer manner while preventing falls, or even wheelchairs, whether that's a manual wheelchair or a power wheelchair. And the idea is that we want somebody to be as independent as possible while still participating in all the activities that they choose to, even if that means using a wheelchair for those longer distances, just so you can be able to participate out in the community and events that you're wishing to. This next slide shows various different bracing that we'll use for weakness, for that hemiparesis or hemiplegia that somebody might have after a stroke. The top two images are specifically for ankle weakness, with the one on the left being like a carbon fiber AFO and is a little bit more lightweight. And the one on the right is a more customized ankle foot orthosis that somebody can use that's having a little bit more weakness and needs something customizable. And then that bottom one is for somebody that has more ankle and knee weakness that can help advance that leg for when they're walking. And then that bottom right image is just for somebody who also has ankle weakness to help lift their toes up a little bit more. All right, so once we go through the evaluation and get a baseline for somebody and how they're moving around and set goals, we're going to go through physical therapy treatment to help that individual reach their goals.
And we're going to work on a multitude of things, all with the primary goal of improving somebody's mobility. I would say the guts of what we work with a lot of people is probably their walking, just because most people's goal after having a stroke is to get back to walking if they weren't, or to mobilize or normalize their gait pattern. And there's a number of ways we can do that I'll touch on in a little bit. We'll also work on posture. A lot of people after a stroke tend to want to lean to one side, and that's a huge component that affects mobility. We'll work on transfers as well, how easily somebody gets up and down out of a chair, and give ideas and pointers on how to make that easier, as well as work on strengthening that'll help improve all of those things that we just talked about. Range of motion is a huge thing for anybody after a stroke, especially for those people that do have that spasticity. And if we're able to relax that a little bit, it'll help improve those gait impairments and difficulty with transfers that we might get. We'll also work a lot on balance. We want to make sure that patients after they've had a stroke aren't falling. And so not only are we working on improving their balance, but we're also working on improving their confidence so that they're able to do things that they were doing prior to the stroke confidently without being fearful of falling. We do have some specific equipment here at Sanford and Fargo that we use for people that have had a stroke. And I'm going to touch on just a couple of pieces quick. So one of our new devices that we got that we use often for people after they've had a stroke is our FES bike. And this uses functional electrical stimulation to evoke muscle contractions in muscles that are maybe weak or are unable to contract on their own. The way this machine works is it's a bike. So we can bring a wheelchair or a chair right up to the bike, and we hook their legs into the pedals that you see on that picture. We connect electrodes to each of their muscle groups in their legs. And there's also an arm ergometer that OT can use for upper extremities too, but I'm going to just speak on the lower extremity use of it for this presentation. But anyways, we can connect electrodes to each large muscle group in a patient's legs or hips. And then the bike will actually stimulate a muscle contraction in sequence to how somebody would ride a bike. So if you think of how your muscles would contract as you're riding a bike, it carries over to your walking as well. And so the idea is that it's going to inhibit some of those compensation patterns that somebody that has a stroke gets when they're walking, and then also strengthen some of those weak muscles so that we're getting that carryover for walking and transferring. We also, another piece of equipment that we have that uses the functional electric stimulation is called the BioNest. It's got this cuff that wraps around the lower leg. And this more specifically is to elicit a muscle contraction in the muscles that pull your toe up when you go to take a step. The way that it activates is based on the angle of the leg when a patient is walking. And so it'll automatically evoke the contraction when they're about to swing their leg forward based on the angle of the leg. And both of these devices can be used more specifically for like strengthening exercises as well, where we can take, like specifically for the FES bike, we can take all those electrodes off the bike and do basic strengthening exercises, specifically, maybe working on TA or someone's hamstrings with just basic exercises on the mat or sitting down or standing up or what have you. Another piece of equipment that I wanted to touch on is our Lightgate body weight support harness. And we like to do a lot of treadmill training with this. As you can see from the picture, there's a harness that wraps around someone's hips, and then there's a piece that goes between the legs underneath. And the reason that I like this device so much is we're able to kind of pull the whole piece up so that somebody can walk in an anti-gravity position in a safe manner. When we put somebody in that anti-gravity position, we can really hone in on preventing those compensation patterns when somebody's walking and try to facilitate normal movement patterns. If I've got somebody with an involved stroke on this machine, usually I've got a person on either side helping advance either leg in a normal pattern, as well as maybe somebody behind the patient on the hips, trying to facilitate that hip rotation. We can also, especially if we have this over a treadmill, we can control the speed at which somebody's walking and maybe provide a little bit more repetition for them. Overall, as PTs, our goal is to help our patients be as independent and safe as possible to allow them to participate in activities they enjoy. So our goal is really just to focus on each patient individually and make them independent in whatever way possible, whether that's strengthening exercises, balancing exercises, and help them maintain those improvements after they're done with therapy to get back to their life and be able to do it either in the way they were doing it prior to the stroke or using compensations as we talked about. All right, I think we're ready for questions. This one. Oh, this one's yours. Yep.
Do I need to?
All right, let's see. Good job, ladies. So do you work with neurology movement specialists with post-stroke or TBI patients?
Are you referring to, are you referring to like a neurologist who just specializes in movements? Like for us it'd be most time it's Dr. Harlow, or is that what
Yeah, Charlene, if you put it in. So yeah, it just says neurology movement specialists. Charlene, if you want to add more.
Most of our stroke patients that we see on an ongoing basis, I feel like they have follow-up with like a Marie, a physician, a PM&R, physical medicine and rehab provider, and then also a neurologist. So it's I don't know how they're assigned which neurologist they get, or if it's just whatever neurologist has an opening. But our specific at Sanford here, our movement disorder neurologist works with more of I would say Parkinson's, Huntington's, the chorea types and dyskinesias, those and different progressive neurological diseases in that respect.
Okay.
I would agree with that.
Yeah.
Okay. Good. Otherwise, anybody else with questions? All right, everybody's probably wanting their tummies are grumbling. But yeah, that was great. Thank you for all the information. We have your contact info if we get any questions that come up, but otherwise we will let you guys go to lunch. And if anybody wants to come to the social lunch too, you can click on that link. It is okay. Yeah, and we still are going to start. I know we went over just a tish. We are still going to keep on track though, so we will still start again at 12:45 with our power hour. And what am I missing? If you want to do the social lunch, you can also leave this open, this Zoom, and the other one should work kind of side by side, sort of, but that's up to you if you want to do it that way. So hopefully we'll see, excuse me, some of you at lunch. Otherwise, we'll see you back here in 37 minutes.